guess if I can get all these technology issues set up. Okay, so SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering support of those who have been there. So we're all peer-based. SHARE provides many services, including a helpline, support groups, and educational programs such as this one, and all the services are free of charge to all participants. And so for more information on that, please go to our website at sharecancersupport.org. As I stated, this program is going to be live streamed to Facebook, and we're actually going live now. So if you do not want to be seen on Facebook, just recommend that you go ahead and turn off your cameras. And with that said, feel free to post your questions in the chat box. We'll also be posting, asking questions online on Facebook, and it's going to be recorded as well. And so with that, I'd like to introduce our lovely speakers, and I will start with Dr. Yara Robertson, who is a board-certified general surgeon and fellowship-trained breast surgical oncologist. She's been in Atlanta, Georgia since 2011, providing quality breast cancer care, and has been passionate about eliminating disparities in breast cancer treatment, especially in the African American community. Her lectures on breast health, breast health, and participates in numerous health fairs, providing free clinical breast exams. She has previously served as vice chairman of Sisters by Choice, a nonprofit organization that provides education and free breast health screenings to uninsured women, as well as support for women diagnosed with breast cancer. As a kidney cancer survivor herself, Dr. Robinson is fully aware of the importance of patients' role in shared decision-making and advocates for patient-centered care. Dr. Robinson believes that women who choose to go flat after mastectomy deserve surgical result that is aesthetically pleasing to them and fully supports the mission of not putting on a shirt. With that, we'll come to our next speaker, Kimberly Barrels, who is a scientist, artist, mother of two, and founder of Not Putting on a Shirt. She decided to go flat in 2017 as part of her breast cancer treatment plan. But her plastic surgeon intentionally left her with excess tissue to facilitate reconstruction. Kim went public with her story, and upon realizing that flat denial was a systemic problem requiring institutional change, decided to invest in pursuing parity for flat closure and helping women protect their choice. This is some long bios. Kim has also been featured in Cosmopolitan Magazine's Women's World of the World and on the Today Show and more. Also with us is Angela Jersi Baker, who was born and raised in northern New Jersey and now resides in Charlotte, North Carolina. She is a mother of one son who is the light of her world. She has a BA in Business Administration and a Master's of Science in Organizational Development from Pfeiffer University, as well as Six Sigma Green Belt certification. In Angela's professional career, she worked as an international transportation industry for over 21 years. In 2015, she founded her nonprofit organization named Angels in Disguise, which is a nonprofit 501c3, and her greatest accomplishment is seeing Angels in Disguise Inc. celebrate 5 years. Congratulations on that, Jersi. Jersi is an advocate in the breast cancer community and volunteers her time advocating with many breast cancer organizations, including SHARE. She was diagnosed with DCIS in 2003, underwent full mastectomy and reconstruction, and then in 2010, had a local recurrence, and in 2011 became metastatic. In 2016, Jersi decided to explant her implants and now calls herself the Uniboob Girl. Jersi is recently developed liver mets and is currently on her 3rd line of treatment and has never had IV chemo. Wow, I'm actually surprised that you've never had IV chemo, Jersi. But yeah, so with that said, like I said, we're going to make sure that everybody is muted and we can go ahead and start the presentation. So
where do we start?
Dr. Robertson, did you want to go ahead and start with?
Yeah, so let's talk about what aesthetic flat closure means. So for me, it was never a definition. It was just the way you did a mastectomy. Now, I want people to know that people aren't trained that in general surgery. So when I went through general surgery training, we actually were blessed with a breast surgical oncology fellowship at our institution. So the 3rd-year residents would rotate with the breast service for about 2.5 months. So on that service, you learn how to do mastectomies, lumpectomies. It depended upon what surgeon you were with how well they closed the chest wall. And most of our women did get reconstructions. So when I became a fellow, the surgeons that I worked with trained us. It's not a formal technique that you do. It's being cognizant of how much tissue you have left on that patient, both what we call medially and laterally. Medially means closer to the sternum or the breastbone, and laterally is near the axilla or under the arm. So if you look at some women who've had mastectomies without reconstruction or they've had the implants removed, sometimes you'll see tissue left near the sternum. It looks like a dog ear. We call it a dog ear. Or you'll see a lot of tissue, we call it redundant tissue, where the tissue kind of billows out or kind of sinks in, especially after an implant has been removed. And so if you want to wear a prosthesis after you've had the implant removed, it's not going to fit very well against the chest wall with all the excess skin. Plus it can become irritated. And then a lot of ladies will complain under their arm of all that fatty tissue. It's hard to put the arm down. It's unsightly. It doesn't fit into, your post-mastectomy bra very well. So it's having an aesthetic eye to understand that tissue needs to go. So I will admit, when I became an attendee back in 2011, my ex-partner, but the partner I worked with, actually really helped me to see different techniques. And it's hard for me to describe the techniques, but she had me to think logically on how to remove that excess tissue. So removing a breast or a mastectomy, for me, does not take very long. I mean, I've done it so many times, it probably takes me no more than 45 minutes to an hour to do a mastectomy on a patient. The longer portion of the procedure is closing, because the number one thing I want to make sure of is that person is not left with cancer. The cancer operation is the most important thing. But the second thing is making sure that woman has an aesthetically pleasing incision, because that's all she sees. And so we take the time, actually it takes longer to close up. That's what I call it, closing up. It takes much longer because we're sitting there actually looking at that tissue that's left on the side and deciding how to remove that tissue. Do you mind if I show my slides really quickly?
Yes, please, go ahead.
Okay. Are you able to see?
I see it.
Okay.
Wow.
So you all probably know this patient. This is her name is photo credit. I got full credit to have her stuff, and she wanted me to tell you her name, Stephanie Asalos Jones. She is a patient that I met about 2 years ago. She had gone to a surgeon in her local town to have mastectomies. She did not want to be reconstructed. She was very clear about that, and had told the particular physician that she had in her mind what she wanted as being flat, and the surgeon had in his mind what he thought should be flat. He made a comment about her not wanting to look like a boy, which I thought was not a very good comment to make by being flat, and that he just kept trying to push her into getting implants. So when she woke up from her surgery, she ended up with this cosmetic result. Now, I will admit that I have never, in my practice, I have never, our patients don't typically look like this, because if you tell me you want to be flat, we make you flat. We don't leave excess skin trying to convince you to have implants later down the line because you've made your decision. This is what you want. So I'm going to use I don't know if I can use my pointer here. This is what we call lateral. And so this is what I call the big dog ear. all right? And all of this tissue should not be left behind if you want to be flat. If she tries to put a prosthesis on that, that's not going to fit very, very flat against her body. And also you see all of this tissue. That is way too much tissue. Another thing is sometimes people who are not, who don't do a lot of mastectomies will leave breast tissue behind too, which for an oncologic standpoint is not safe. So you have to make sure you know how to do a proper mastectomy and how to flatten the tissue out. So Stephanie came to us for just a revision. She wanted her chest wall to be flat. And this is not her, but this is a picture that I found. This is the problem that a lot of surgeons have. After we remove the breast, this is the pectoralis muscle, and that's a drain that we put in afterwards. We have this excess tissue right here. So you have to look at that, and I like to do it before we even go to surgery. The patient's usually sitting up in the pre-op area, and I'm marking out where that arm is, where the axilla or the underarm is, and how their range of motion, because when we close you up, if we close you too tight, you will have restriction. So this little area here, this little flap, there's two ways that I typically do it, is I make sure I start at the medial portion, which is near the sternum, and I start cutting excess skin as I close up to make sure that it's not too tight so it doesn't necrose or the skin won't die off. But I keep closing from here all the way over, and I'm cutting more tissue off. As you can tell, this takes it takes extra time to do, but it's worth it because that patient, when she wakes up, she's going to be happy with her chest wall. And then when I get to the end, all of this tissue here, I will usually measure out and I will cut off because I have to put it in my op report how much tissue I took off. But if you take the time to remove this tissue, you won't have that big lump here on the side, like this patient here. So this is her post-operatively, and I did this side. My partner, I believe, did this side. Honestly, it's been 2 years. I can't remember, but I think she told me I did this side. So you see how and I like to connect this in the middle just to make it look flat. Sometimes I do it, sometimes I don't. But that keeps them from having those dog ears that stick up. But she was so happy after we did this procedure because this is how she wanted to look. In her mind, that's how she wanted to look when she woke up. I can't blame her surgeon for a miscommunication. I think that particular person really thought that she had not made up her mind about implants and just want a just in case. And if somebody says they don't want to be reconstructed, as a surgeon, it's not my right to think for you. I can't make that decision for you. Now, if she decides down the line she wants to have reconstruction, she can see the plastic surgeon and they can take tissue from her back or her stomach or other places to make a breast. But as for the decision she made, this is how she wanted to look. So this is her at her 1-year anniversary, and she made sure she tagged me because she was so happy of how she looks. So if you see her, follow her on Facebook at Flat is Where It's At, because she is the one that actually told me about the flat closure movement. I had no idea that this is actually in movement because this is what I thought people just did. I didn't have any idea that people were going to see physicians and they were making the decisions for the patient saying, hey, you don't want to be flat. You need breast tissue. That is not what we do. And I want to stress that when you go see a physician or a surgeon, make sure that surgeon not necessarily is fellowship trained, because the majority of doctors who are doing your surgeries out in the community are not fellowship trained. My partner's not fellowship trained because there was no fellowship when she was going through, general surgery. But they have to dedicate a significant portion of their practice to breast patients and make sure they're doing more than 2 or 3 mastectomies a year. If they're doing a few mastectomies a year, you probably don't want them doing your mastectomy because they're going to do you the old-fashioned way. And they'll say, just be happy that you don't have cancer. But we know that in addition to removing the cancer, just having the surgery doesn't mean that you're finished with your lifelong, you look at your breast tissue, you look at your incisions, we call it a pink badge of courage. You have to look at, there's not a day that goes by that you don't remember you had breast cancer. So why would you want to look at a horrible looking chest wall and being disfigured? That has a lot to do with the psyche of a patient. If you're already, having emotional issues or depressed about breast cancer, can you imagine getting up every day looking at a disfigured wall like that? And then not even knowing where you can go to have that fixed. That's totally inappropriate. So when we talk about decision-making, shared decision-making, it's really important to sit down with your surgeon and go, okay, this is what I want. Now, when patients come in and tell me that they don't want to be reconstructed, we actually talk about it. Why don't you want to be reconstructed? Because sometimes there are misconceptions. They talk about the implants that can lead to a certain type of cancer. Well, it's very rare, and most of the time, the surgeons that I work with don't even use those implants. But that's a good discussion to have. If my job is to make sure a woman is comfortable with her decision when she goes to sleep for surgery. I've had women come to the pre-op area right before the surgery and go, "Doc, I changed my mind. I want it removed and I don't want reconstruction." We cancel the case for the day because there's been a change. We need to have a clear, process. I have her come back to clinic and we talk about what she wants. And sometimes she'll change her mind right back to what, that she wants to be reconstructed. But I don't like making those decisions in the pre-op area because once I remove the breast, I can't put it back. Once we reconstruct you, I don't want her waking up going, "I hate this, I want this gone right now." We need to make sure that she understands what's going on. So you need to have a clear idea and ask for pictures. And one of the issues that I have found is there are no pictures that look like my people. There's not a lot of, there's no pictures that look like African Americans. They don't show you a reconstructed breast with African American skin. You don't know how do you look when you're flat. So we have to do a better job of making sure we are representing all of our patients, more diversity. But you all can go ahead. I can keep on talking.
I'm so grateful that you're here to speak to this issue because you have such a great experience and such a healthy perspective on it. I mean, if every surgeon had that same mindset, we wouldn't be here today talking about this because it would just be the way things are, like you said. And there's at least 100 women in my Facebook group who were intentionally denied a flat closure, intentionally, where the surgeon would say, I did that in case you changed your mind. And that's just a small sampling, that's not representative in any way, shape, or form, but it speaks to the need for, a dialogue about this. And I really appreciate it. Appreciate it. Yeah.
I think that I read, on your page, you all were wanting the American College of Surgeons to make some changes. I will have to look into that because I have to see how that can be possibly done, because in the general surgery training, unless they have fellowship trained breast surgeons or an actual program, I don't know if general surgeons are going to take the time, and I could be completely wrong, to develop a curriculum for this. Most of the time, the breast surgeon is the one removing the breast, so it's usually not the plastic surgeons. When I'm doing a mastectomy, the surgeons are not involved. So, and I actually had to. My plastic surgeon that I used here, I love him dearly, but when he wanted to take implants out, I would actually demand to be in the room to take the implant out myself, because we would always fight over the amount of skin. He wanted to leave skin in case she changed her mind down the road, and the patient clearly said she didn't want to have an implant again. So we would actually, I'm not mean, but I was just kind of forceful that let me close, please, because I know I do this for a living. I close skin, you reconstruct. So we kind of came up with the nice, plan that I made to let me close up when I take the implant out, because I know how to make them flat. The patient doesn't want to wake up with stitches they can see. We call them running stitches. And the stitches that are not absorbable, they don't want to see that big zigzag pattern across their chest wall. So I prefer to close if they have to remove the implant and the patient's not wanting the implant back in. Now, if the patient wants an implant back in, I leave the skin alone and I leave that for the plastic surgeon. I don't mess with his skin if she wants her implants down the line back in. But if she wants to be flat and she comes to me first, I'm removing the implant and I'm making her flat. And I'll get an angry phone call that I took too much skin. But you know what? It looks better.
It looks better, and it also feels better. And I have to say, you were mentioning that it could be, difficult if a patient expects to look one way and wakes up another way, like Stephanie did.
Mm-hmm.
It is, I can speak personally to this, but also from the women that I've met who've had similar things happen. It's really traumatic because you make peace with your choice. You make peace with what you're going to look like when you wake up. You don't know exactly, but you have a fair idea. And then you wake up to something completely different. And on top of that, you hear your surgeon say, I did that in case you change your mind. I can't tell you how traumatic that is for the patient. And it's a matter of, you know, informed consent, right? But it's the reason why, in my mind, the term aesthetic flat closure being defined in the National Cancer Institute's dictionary, the reason why that's so important is because there's no ambiguity about what you mean when you say flat now. If you say you want aesthetic flat closure, the NCI has already defined it that it's removing all the excess tissue and contouring to make a smooth, flat chest wall contour. There's no you know, question about what the patient wants. It's clearly defined. So that was, in my mind, the importance of that term. And
well, sorry, if you go to a surgeon and you want to be flat, I would have them show you pictures of what your expectation, like I would show them, this is what I expect when I wake up. Now, nobody's perfect. Everybody has a different body habitus, and women who have more adipose tissue or fatty tissue or more skin, we can't always make you as flat as possible because we can't keep taking tissue. We'll be all the way around your back trying to make you flat. So sometimes we still have excess tissue there. So you have to have a realistic expectation. So some of the women that are bigger, I will tell them you will be left with some skin because we can't remove all the skin because of your size. But we need to make sure we do a good job making you as flat as possible. So I think if you go to sleep with the idea of what you will look like, possibly, or show pictures, I think it'd be much better. And you want to make sure your surgeon knows how to do it. If they're already poo-pooing the idea of you being flat, that should be a red flag right there. Now, I send my patients to the plastic surgeon when they want to be reconstructed, and the majority of my patients want reconstruction. They want to be reconstructed. I will say that when they have advanced stage disease, stage 3 disease, and they need to have radiation or things like that, I'm a little bit more hesitant. I really want the cancer treated first. If they have to have radiation, I'm really not wanting them to get implants in. Expanders can sometimes be a beast of their own when radiation changes. As you heard, my patient was having issues with her, radiation and had to have her stuff removed. So, I would prefer for them to be flat for at least a year, have restaging, meaning we go back through the CT scans, MRIs, PET scans, make sure they're cancer-free, and then send them back to the plastic surgeon to be reconstructed. I really want them to be patient on that because the longer you wait for the radiation changes to die down, so there's not so much damage to the tissue and blood vessels, you have a better reconstruction if that's what you choose to do. So just an informed patient is a good patient to make decisions. I find that if patients don't understand what's going on, they don't make good decisions, and they make decisions in fear. And it's the physician's job to make sure you are comfortable, that you have a good understanding of what your disease process is, that you understand the treatment plan, that if you need radiation, we kind of have you see everybody before you have surgery, so it's not a surprise after the surgery. And then also some patients will come in thinking that they can have their surgery immediately, and some people have to have chemo before the surgery, and they want to know why they can't get their implants or their reconstruction when they have to have radiation. We are guilty as physicians of talking at patients and not to patients. We have to learn how to make sure the patient is heard and you speak in a language that they can understand, if that makes sense.
It does, because part of the informed consent process, I was just talking about this with some international advocates just yesterday, the last piece of informed consent is that, the patient that's going to give the consent understands the pertinent information. It's not just presenting the information, making sure they understand.
Goldilocks. Goldilocks is done by our plastic surgeon, and so we do. The Goldilocks, yeah, so I don't do the Goldilocks. That's our plastic surgeon. So what happens is women who are larger, who have higher BMIs, putting implants in them, sometimes they come out horrible. And I will be honest, they look like pancakes, and nobody wants to look like that. You go to sleep to have a mastectomy with reconstruction, and you come out with your breasts flat looking like pancakes. That's horrific. So what we started doing for our patients that are a little larger is that I will come in and I remove the breast tissue. The plastic surgeon comes in and kind of does, he folds the fatty tissue that's remaining and makes a mound that looks like a breast. There's nothing in it. There's no implant. And honestly, a lot of the ladies have not gone back for reconstruction. They just want to keep that mound with no implant in it, and they're very happy with it. And so the idea is that a few months later, you come back in and put an implant in those patients, and it looks so much better than doing an implant immediately. But that was a question about the Goldilocks procedure. I don't do it, a plastic surgeon does it.
May I ask a question?
Yes.
Okay, I'm JK.
Oh.
You were talking about informed consent and the person understanding. What I've noticed, I'm a hospital chaplain, and I noticed that people, when they're in the hospital with different things going on, they're in different states of mind, so that sometimes they hear something and then that colors everything else that's going to follow, and they don't really hear it in the way that it's offered. And so I would imagine you've had the situation too, where you've had several different visits with somebody where they get used to the idea. The first time they just might dismiss it or something, and then you stay with them and approach it from a different angle. And as they get more used to the idea, and they can stop having reactions, but start listening to the underlying information, then you're having a conversation. Many surgeons and physicians don't go that route, and they just, oh, she didn't understand, I can't talk to her, and that's where they end it. But people really have ideas about how the world works in every situation in the world, and when it comes to their own body, they also have an idea about how the world works. And if you're telling them it works differently, they can't hear that at first, and they have to hear it several times. Maybe they want a second opinion and they want to hear it from a second person. Maybe they need to talk to a social worker or a navigator or somebody else who can say basically the same thing, but in enough ways that they can actually hear it. So I just wanted to say that a lot of times patients are just dismissed because, oh, they didn't understand, oh, they don't want to talk, oh, they're just angry. But there's a lot of things going on, and often breast cancer is just one thing in their life even. So thank you for being the advocate for your patients, even in the operating room, to make sure that they get what they really want. Thank you so much.
There is a patient that's on here, and I'm not going to say her name, but if you were at the beginning, you would know who I was talking about. When she came to see me, and she knows when she came to see me, oh, she's the type of patient that you would have thrown out your office because she was so amped up with being diagnosed. And the reason why she's on here, and the reason why we're so close, and the reason why I'm gonna miss her when I move away, is because I worked with her before we even touched her, because she had to accept she had breast cancer. And breast cancer is not a surgical emergency. When you get your diagnosis, it doesn't mean that you have to have surgery yesterday, because it's been there for probably 5 to 10 years, the cell's growing. It's not like you find out. I always call it a mental emergency, not a surgical emergency. We have time to make decisions. You can't be an informed patient if you're making decisions in a frozen state. As a cancer patient myself, you have to get over the initial shock of cancer so you can start making decisions and fight. But you don't have to get over the cancer in like 2 hours. I hate it when I've heard patients come in for like a second opinion and they go, the doctor walked in and said I had cancer and said I was having a mastectomy and said I was gonna have this. And I said, well, what type of cancer do you have? Oh, I have no idea. He said breast cancer. Well, what type of breast cancer? I don't know. Have you looked at your path report? No. Do you know anything about breast cancer? I don't know. I don't know a thing. So I start all over from the beginning. This is what breast cancer is. This is the type of breast cancer you have. This is what we need to do. So it's a mental emergency, not a surgical emergency. You have time to make decisions. So the patient that's on here that I'm talking about, we had to work with her. We didn't just take her to surgery. I had to bring her back several times to discuss things until she had a very good idea of what her cancer was, what we had to do, and make sure that she felt comfortable and not so anxious that that she wasn't going to survive her breast cancer. I do not like it when like a patient comes in and will have misconceptions about chemotherapy or surgery, you know, the old wives' tale. If you open me up, cancer will spread everywhere. You know, it's the old wives' tale. But you don't laugh at the patient. You just dispel the myth and make them comfortable. Some patients don't want to have chemotherapy initially, and you have to have them have to be able to make them understand why they need chemotherapy. You don't force it on them. I have some patients that decided eventually to have chemotherapy after several months, but I didn't just discharge them from the clinic. I would have them come back and I would talk to them a little bit more about why they needed whatever they needed. You just don't throw your hands up and say, well, if you're not listening to me, go somewhere else. That's not what you do. And if I don't feel like I'm reaching the patient, which is not very often, my patients don't usually leave me because I'm understanding. They usually stay with me. But if I feel like I'm not reaching that patient, I will send them for a second opinion outside of the hospital system. So maybe somebody else can reach them better. And if you ask for a second opinion and your doctor acts all crazy with you, you need to get away from that doctor. Because even for my kidney cancer, I got a second opinion. And if I had not got a second opinion, I would have been left with cancer because my doctor changed the whole operation, which found extra cancer. So if you want a second opinion, get a second opinion. Now, when you get to the sixth opinion, we're gonna have words. That's too many opinions. You need to make a decision on what you want to do and stop dragging your feet. 6 opinions? Nah, that's not happening. We need to talk. But you know, a first opinion, second opinion, I can even go with a third opinion. But when you start getting multiple opinions, then you just start getting confused. You got to make a decision on being timely treated. But surgeons, physicians, it doesn't matter what your ailment is. If you don't understand what's going on and you don't feel that you're getting the connection with the physician that you need, go somewhere else. There's a doctor for everyone. And some people may not like me when they come see me. And if we can't make that common ground, it's okay to see someone else. The most important thing is for the patient to be treated by someone accurately.
Dr. Robertson, 2 things that you said that really resonate with me is, one about the African Americans and probably we don't see as many flat, but so with my nonprofit organization, I drive cancer patients to their appointments, but I'm an advocate, so I go inside with them pre-COVID. Mm-hmm. And one and I call them my vidas, which means life. And one of them invited me to come to her consultation. So it was like her team of doctors. And she already knew that she wanted to be flat. She was having a double mastectomy and she wanted to be flat. And he like alluded to like, we'll leave a little extra, whatever. And I looked at him and I was like, she wants to be flat. And he's looking at me like, who are you? And I was like, I'm an advocate, but she just told you what she wanted. So like, who are you to try to, convince her otherwise? She was like, my breasts are already small. I don't need them anymore. And she really wanted to be flat. So, it was disturbing just that he even fixed his mouth to try to discourage her from what she wanted to be. And then with me, how you said about radiation. So I've never had traditional chemo, but once I became stage 4, I did have radiation, and my breast implant, it would start like dying would have been better. Like it was itching and burning and it was so bad. And like, I couldn't take it anymore. And I went to like a neurologist and he was like, yeah, it's the implant, you should get rid of that. And I listened, but I didn't get rid of it. And then I went back like a month later and he's like, you still have that implant? And I was like, oh, like, yeah, I really should take it out. And for me, it was the best decision I ever made for myself. I never thought about like walking around a Uno boob girl. Like it didn't matter to me. I just knew that I was getting rid of this. And I guess until I had to put on a bathing suit and once I was flat, I was like, oh, I only have one breast. But so that really resonates with me about the radiation.
I don't think anybody should feel bad about the decision that they make, whether you want to be flat or reconstructed. I like reconstruction. Patients will come in and ask me unfair questions all the time. What would happen if it was you? Well, I can't answer that question because it's not me. I will not tell a patient what I will do because it's not me. I don't want you to, I I don't know if you ever noticed sometimes, as being a medical student, when I was a medical student, I would watch certain physicians talk to the patients. And when you wanted them to agree with you, as you talk to them, you shake your head. So you want to have a mastectomy with reconstruction, don't you? And the patient goes, yeah. You have to be careful not to lead the patient. So I don't tell a patient one way or the other because my family history is different. I have a strong family history of breast cancer. So yes, I say I'll have bilateral mastectomies with reconstruction now, but I don't know how I'll feel after me going through a different cancer. I'm not too keen on having another surgery anytime soon because I had a huge operation. So I may say one thing one day, so I don't tell the patient what I will do. It's your decision ultimately. And I always tell a patient, if you get reconstructed and you don't like it, and they come down the road and what I get asked is, I should just remove both breasts, shouldn't I? That's a personal choice, okay? If the other breast has no cancer in it and we've checked it out thoroughly before the surgery, I, in good conscience, cannot tell you to remove a breast that doesn't have cancer. I always explain it like a ice cream shop. Some people like pistachio, some people like strawberry, you might like cherry. Just because I like pistachio doesn't mean you got to eat my pistachio. So if you want to have just one side done, we can bring you back at a later date to remove the breast prophylactically. You see how you feel with the one breast being gone. So you don't have to make that decision that day.
Right.
The other thing is if they want they want their breast removed or they want the implant removed at a later date, I really have them think about that first. We want to make sure there's no, because insurance sometimes gets crazy. But so we want to make sure if they have any type of, we do MRIs to make sure it's not leaking or anything like that. But if we need to remove it down the line, there's only one lady I can think of in 10 years, and I begged her not to remove her implants because I knew she wouldn't be happy. You have to know your patients too. And sure enough, within 2 years, she was upset she had removed her implants. And I don't think the plastic surgeon wanted to put her implants back in because it was such an ordeal to begin with taking them out. So you just need to make sure you make the right decision, but it's not for me to lead you. I don't think that we can be flippant with our remarks to patients, and what we may think is something that is very minimal. A patient who's just been diagnosed with cancer, it can mean everything to them, and they may leave your office, crying and distraught. So I think if a patient comes in and says, I want to be flat, to say, I'm going to leave you with a little extra skin, he may not have thought that meant anything, but to that patient, you're not listening to me.
Right.
You did not hear what I said. So we have to also be cognizant of how we talk to patients and the things that we say, because I can tell you, he probably didn't even think a second thought about what he said. Not that he was trying to force her to have anything. He just assumed this is what this patient will obviously want, because this is a woman and her breasts are part of her sexuality and she needs breasts. That's how a lot of us think.
Right.
I'm not going to advocate for a female breast surgeon because I know a lot of great male breast surgeons. So I'm not saying that you'd have to have a female breast surgeon to have a good cosmetic outcome. I just think you need to have a physician that is well skilled with doing breast cancer care, that you can have a good discussion with, that understands what you want and have a clear picture of how you want to wake up. And to also be honest with you, if you don't think you can make a person completely flat, let them know that. I mean, I'm not going to give you false hope because I don't want you to wake up angry with me. Often patients will wake up because we make them so flat, they see their stomach. And, they see that stomach before, and they argue with me that I put something in their stomach. I was like, honey, that was you before. So that's the biggest thing. We sometimes make them so flat they can see their stomach. But, you want to have an actual, you want to be very clear with the patient on what you will look like when you wake up. So in our practice, well, my former practice, if I knew a patient was there who had been reconstructed, or a patient who was there who had had a mastectomy and is flat and the person's trying to decide, most of you all are show and tell people. Y'all don't care where you are. You'll be in the waiting room. I have to go out and tell you to stop. You're flashing folks. So you can easily get a patient to come into the room and 9 times out of 10, they don't mind. I'll say, Miss Jones, would you come in and show her how she looks flat? And so the patient will come in and show, doesn't mind showing her. And then we'll have someone with reconstructed and they'll come in and show her. And the patient may make the decision, oh, I didn't know how flat would be. This is actually I like that. I want to be like that. Or they may say, hey, I like this reconstruction. This is not what I thought it was. Yeah, I'll do that. So sometimes show and tell is good too. So if you're advocating and you could, if you have support groups, show people what reconstruction and flat looks like, and it helps people make better decisions. That's even more powerful than a picture.
Mhm. That's one of the things that the private Facebook support groups online, even in the flat groups, if someone comes in and they're not sure whether they want reconstruction or not, we always say, join a deep flat support group and go in there and see what your options really are and see what other women will share with you. In this group, we're going to share our flat pictures and you won't get pictures of reconstruction. But if you're still in that space where you're trying to make your decision, I completely agree with you. From the patient's perspective, it's always really helpful to see pictures. It's definitely would be better in person, but I think for most people, just joining some Facebook groups and just seeing, what's out there, it's important to get balanced information.
I'm kind of glad that like I had the experience of having an implant and then and then now I don't. Because when I was initially diagnosed, I was 32, so breasts were probably important to me. And, probably flat would have been like, what are you kidding me? But now I love it. It's so freeing, and sometimes I wish I didn't have the other one, but it's who I am, and I love it, and I like to be able to talk about it and share and tell people to really think about, like you said, really think about your decision and don't let anybody force anything upon you.
Right. Yeah, I think those are all excellent points. I know when I was making my decision, my surgeon was immediately, okay, we're going to do the mastectomy. Let's get you to the plastic surgeon. And I went to the plastic surgeon and just said, educate me on what all my options are, right? And including being flat, right? Because like Kim and I have spoken about it. There's so many reasons why women decide to go flat besides just not wanting to have an implant or having the second surgery. There's so many lifestyle aspects that come into play. And you need to not be afraid to talk about that, right? And express that to your doctors to why you want this. Not just that this is what I want, let's let them know it's something you've actually thought about, done the research on, spoken to other women about it, and it's still ultimately a personal decision.
Yeah, it's so important for patients to share their values and priorities and preferences, and that is their decision-making process. And if your surgeon doesn't understand what your process is, they're more likely to make assumptions that might end up giving you a result that you're going to regret.
Yeah.
And you have the right to slow down. Like I said, don't drag your feet months and months and months. But you don't have to make a decision on the surgery the day you get diagnosed with breast cancer. Just from my cancer, well, I had to say my cancer, the cancer that I had, it is when the doctor walks in and tells you you have cancer, you're in a fog. I don't think the only thing I asked my urologist when he finished with drawing pictures and this, that, and the other, in my head, I kept thinking he has the wrong chart because that's definitely not my chart. I don't know what this man is looking at. I didn't know I have patients to see. I know what he's talking about. While he was talking, I heard nothing he said. And the only thing I asked him was, can I still take my trip? He said, that's all you have to say. I said, I don't know what else to say. So if he had tried to tell me what surgery I was having that particular day, it would not have been well received because I needed to process that he had just told me I had cancer. So you shouldn't be making a surgical decision. And when patients are rushing to make a decision that day, I have to slow them down because those are the patients that will have a breakdown after we finish everything because they have not processed what's going on. So it's like, hurry up. And then when everything is over with, they go, I had cancer. So that's not the normal order of how we do things. So if you feel like the process is going too fast, which I mean, surgeon walks in and says, we're having surgery, you just got told you had cancer, you need some time. And you have the right to say, I need some time to process this. Now, I always tell patients, if you decide you're going to go to Tahiti for about 6 months, I'm going to come to Tahiti and drag you back to the United States to have your surgery. That's not going to happen. But a couple of weeks to make decisions while we're getting test results back. You may need genetic testing. You got to see all the other people. Yes, let's say you want to see the plastic surgeon too. you know, you got to see the radiation therapist. You got to get all your team together and you want to bring, I don't let patients come to the patient. Do not come to my office by yourself.
I always go by myself.
No, when you're first diagnosed.
I went by myself.
That's not good. And I would have fussed at you and drugged somebody in there with you.
I was 32. Who knew like I really had breast cancer? I didn't believe it.
But, well, it depends. The next time you come back, you bring somebody with you. You need a second pair of ears. You need a second pair of ears because what you hear is different from what I'm saying when you first get told you have breast cancer. And then when you come back again, I'll ask a patient, what were your tumor markers? And they go, I don't know. Because we've gone through that the first go around, but they didn't hear me after I said you have breast cancer. So it's always good I love the fact that my mom came with me, kept a level head while I was thinking all type of crazy stuff, how I was going to murder the urologist for giving me this bad news. She's taking notes. And the questions that I needed to ask him on the next visit, she had already had the notes for me because I wasn't listening to anything this man was saying to me. So you always should go with a second pair of ears. And that person should not be your spokesperson. That person should not be making decisions for you. I don't like talking to the family when I need to talk to the patient, and because the patient is ultimately the one that needs to make the decision. I don't like it when the family's making decisions for a patient who's well-informed, and that patient, you know, when the family walks out, they go, well, I really don't want that. Well, if you don't want that, you don't want family members forcing patients into an operation that they don't want. For instance, I had a patient not that long ago the family wanted her to be reconstructed. She did not want reconstruction. She did not want to be reconstructed. And she listened to the family. She was uneasy about it, but she wanted to do what they wanted her to do. And she ended up with a horrible infection after her reconstruction. And we had to remove the implant and her chest wall was disfigured. Now that doesn't always happen, but for every visit after that, she told me she should have just done what she felt like doing instead of letting somebody talk her into something. So don't ever let people talk you into something that you're not comfortable with. Now, if it's the right thing to do, then yes, you need to do the right thing. But if it's something you're not comfortable with, like reconstruction versus not being reconstructed, then you need to make sure that you feel comfortable with the decision being made. Don't let someone force you into a reconstruction if you don't want it. But also don't let somebody force you to be in flat. If you want to be reconstructed, you have the right to be reconstructed. And your doctor should offer that. I don't like it when patients come in and say that the doctor just said, we're going to do this and that. And I go, well, did you see the plastic surgeon? I can? I didn't know I could have reconstruction. That's not giving the patient all their options. You give the patient every option that's available to them.
And I think that's the key thing. We have some questions here. One being which came up prior to the webinar and it's being asked again. So if one's results that have been discussed are not what they actually get, what would their next steps be? So
well, they need to talk to the surgeon, because ultimately it's that they have the relationship with the surgeon to sit down and say, I always tell the patients, because the plastic surgeons are really quick, they get in and out that room real fast. I say, take your stool and put it between the doorknob in the chair so they can't get out the room, and have all your questions ready for them. But you sit down with the doctor that you have the relationship with and you say, this is what I thought I looked like. This is how I look. I'm not happy. What can we do to fix this? That's what should happen, a discussion.
Okay. Sure. I mean, and it's valid, you know. I think I'm always telling people that one should always have somebody with them, and to ask as many questions as possible and make sure that you're being heard, right?
I would add something to that, if I might interject just for a minute, because what happened to me was my surgeon intentionally deceived me. And then after, when I confronted him, I mean, it wasn't a confrontation. I was just asking, I mean, is this extra skin, is this going to go away? Because it was clear to me that it was not what we agreed on. And his words were, it'll tighten up.
No, it never tightens.
It doesn't tighten, right? So in the absence of like radiation fibrosis, right, or contracture from an explant, yeah, it doesn't tighten. But I'm just, you know, if you're in the consult and your intuition is telling you that something's really wrong, that you're not getting full disclosure, just go get a second opinion. Listen to your intuition. You know, when it comes to your own health and safety, and this is true across the board, but in particular when you're talking about your body, listen to your intuition. If you feel something's off, get a second opinion. And you know, when I did go get a second opinion and a third opinion, they told me the truth. And the truth was that he had left extra skin in case I changed my mind. It was never going to tighten up. And I knew that that was the truth. So I would just add, you know, when you're talking to your surgeon, it's not likely that you're going to experience that, but it's possible. And listen to your intuition.
Part of me thinks that sometimes that's an excuse, though, that doctors use, saying I left you with a little bit of skin just so in case you decide. Because honestly, it takes a lot longer to close that patient up to make them flat.
For sure.
People don't know how to make you flat. They don't.
Yeah.
So I don't know how. It's really up to that surgeon to be transparent with you, to say, I can't make you flat. But I don't know many people that if you're coming to me for a procedure that I'm very honest. If I don't know how to do something, I'm gonna tell you. There's no reason for me to do something to you if I can't do it. I mean, that makes no sense. But I don't know how many people would be transparent to say, I don't think I can make you that flat, and you need to see, you know, somebody else. I've had a couple of surgeons refer people to us saying that she can do, you know, she can do this with you. But there's no way to make a surgeon be honest. And I would like to say the majority of us are honest. I don't think there are dishonest people out there, but the majority of us are honest. But I don't know how we can change that. I don't know how you can change that behavior.
Yeah, I think it's just important the patient needs to be empowered to know what to ask and what answers they're looking for. Because from the patient's perspective, you've just been diagnosed with breast cancer. You're going in to see this surgeon who has, you know, 20 years of training and experience and sees patients like you every day. The expectation on the patient side is that they're going to volunteer all the information you need. And oftentimes that may or may not be true. So my question is, what would you recommend, Dr. Robertson, for a patient who feels like there's like that little like inkling that maybe I wasn't told all my options, or maybe there's something wrong? Like, what is the source of information about reconstruction options that you would recommend? Is there a source, or like, what are their next steps if they're not quite sure that they've been?
I always say get a second opinion. That's really important. Get a second opinion. And then go on support groups, chat rooms. I like breastcancer.org. I like Susan G. Komen. They all have good resources. Breast 360 is wonderful. That is written by breast surgeons, has all of the things dealing with breast cancer care, breast health, has reconstruction, and emailing different people who've been through the process. I think it's so important. You all are a network. One thing with kidney cancer, we don't have a big support group system like you all. There's so many women, like 3.5 million survivors. So everybody's had some type of surgery. It's important for you all to reach out. There's so many people you can talk to. If you feel uneasy about it, take a step back and then go talk to someone else. And also, if you want to stay with that surgeon, maybe make a second visit with them before you make a decision on what you want done. But you can do your research. Now, please don't come into my office with Dr. Google. Please don't do it. You won't come back, because I don't deal with Dr. Google. Because I'm telling you the truth, and I don't want to hear Dr. Google. I want you to have scientific facts and not tell me you're going to do stuff with carrot juice. I don't want to hear it. So, not Dr. Google. You need to, when you want physicians to take you serious. And so I believe in integrative medicine. I love integrative medicine. I believe in Western medicine, and I believe in what we do. I believe there are good medications that you can take to get rid of breast cancer. I also think you can do things like prayer, meditation, yoga, aromatherapy, relaxation techniques, everything you need to do to decrease inflammation to do well after breast cancer care. But when you go in, you want to have, that's why I always say you can't always cover stuff the first time you go in to see the doctor. So you want to go home and process. I always give the patients their pathology report so they know exactly what they have. I give them their MRI reports or PET scans. I make them make a folder of their stuff. Every time they see a physician, they should ask for a copy of their note for the day so they can reread it. And so when they go home, they understand what's going on, so that when you come back to the physician, whether it be a surgeon, a radiation therapist, or the plastic surgeon, you can ask questions. And I say, go home and write down questions. And sometimes I will tell them, give them a pad and tell them to write the answer down for you. They should have time to do that. Now, they may not have time to go through millions of questions every time you come in, but when you have the first few visits, you need to understand what's going on. So write questions down as well. And then reach out. You may want to compare your experiences with other breast cancer survivors, but not everybody's experience is the same. We have to remember that. You know, not everybody's going to have the same cosmetic closure. There's some women who are going to get beautiful nipple sparing mastectomies with reconstruction. They're going to look great. And there's some women that are going to have infections. There's no way sometimes to predict who's going to have a bad outcome. So when you come in and we talk to you, even being flat comes with this risk. If you're a smoker, that incision can break down. If it's too tight, the closure's too tight, that incision can break down. Sometimes if you are around a smoker in the house, the blood supply after surgery, that incision can open right back up. You can get Seromas, which is fluid that fills up the pocket after we remove the breast. So you may have to keep coming in and have drainage. So just because you're getting a flat closure doesn't mean it's going to be perfect either, because there are, you know, complications after any surgery that we do. So you try to go through all the complications with a patient for any procedure that they have. I don't like it when we gloss over stuff, you know, oh yeah, that could happen, but just sign a consent form. That's not appropriate. If you feel like you're being forced into signing something, wait till you have the information before you do it.
Yeah. Well, thank you so much for, I mean, this was so informative. It's very helpful. We are out of time. But I just want to say thank you for providing this presentation, for taking time out of your day, because I know we all have very busy schedules, and I just really appreciate it. And thank you to everybody who joined us. Yeah, have a great night.
You can always reach out to me on Instagram. I answer so many questions in my private message. Feel free to send me messages. I have no problem answering questions. Somebody just asked me about physical therapy the other day. I don't know anything about physical therapy, but I got them where they needed to go.
That's great.
I appreciate you, Dr. Robertson. Thank you so much. She's an amazing advocate. I'd just like to say, and her Instagram feed is pretty fabulous. So check it out.
Thank you for having me.
Take care, everybody.
Bye. Thank you so much, guys.